thrilled to have Dr. Christine Ritchie, MD, MSPH, is the Kenneth L. Miniker Endowed Chair in Geriatrics and Director of Research for the Division of Palliative Care and Geriatric Medicine at Massachusetts General Hospital, MGH. She is Professor of Medicine at Harvard Medical School. She's board certified geriatrician, palliative care physician, and healthcare delivery scientist who conducts research focused on optimizing quality of life for those with chronic serious illness. Along with Dr. Bruce Leff, who I'll introduce in a moment, she leads the National Home-Based Primary Care Learning Network, which seeks to increase the quality of care received by homebound adults in the United States, and leads the MGH Dementia Care Collaborative. Our other speaker, Dr. Bruce Leff, is a professor of medicine at Johns Hopkins University Schools of Medicine. He cares for patients in the acute, ambulatory, and home care settings. His research focuses on novel models of care delivery in older adults, multi-morbidity, risk prediction, and quality improvement with an emphasis on home-based models of care. He is the co-lead of the Hospital at Home Users Group, and with Dr. Christine Ritchie is the National Home-Based Primary Care Learning Network. He is past president of the American Academy of Home Care Physicians and a current member of the Board of Trustees of the American Board of Internal Medicine Foundation. So how about that, you guys? Talk about a couple heavy hitters today. We're thrilled to have them. I'm going to exit stage left and turn the talk over to them now.
Thank you, Dr. Felker, and greetings, everyone. It's so nice to have this time with you, and thank you for taking time out of your day to spend it with us. We're really excited to talk with you today about a special population that we hope to be able to perhaps shed a little more light on, those who are homebound, who are living with cognitive and other behavioral challenges, and know that many of you are perhaps given increasing opportunities to support and serve this population, and we'd love to spend some time talking with you about opportunities to serve them better. So our goals for today is to first talk about this population, what we call the invisible homebound, who often could truly benefit from telehealth. And we'll talk about why telehealth can be beneficial to them and provide you with some general characteristics of who they are. We'll talk about their behavioral health needs, and then we'll spend time talking about strategies for delivering telebehavioral health effectively to homebound older adults, with a special call out to those living with dementia. I want to turn over this first section to my colleague, Dr. Bruce Leff.
Thanks, Christine. So we thought it would be useful to talk about who the homebound are. You may not think there are very many older adults who are homebound. For years, the number of people who are homebound and their characteristics were a bit of a black box. Folks cited data from the US Census, and when you looked into those studies, it was very hard to figure out where those numbers were coming from. About 10 years ago, one of our colleagues, Catherine Ornstein, who's now at Hopkins, led us in a study trying to determine the epidemiology of the homebound population in the United States. And for that, we leveraged the National Health and Aging Trend Study, which is a population-based study. It surveys a random sample of Medicare beneficiaries who are over the age of 65. And by using a combination of in-person interviews and performance measures, we're able to get a general sense of folks who are homebound in the US. About 7,600 folks in that study. There was no predefined measure of homebound, but in that survey, there were questions that looked at the frequency at which people left their home over the course of a month, how difficult it was, whether they needed help or used aids. And in the next slide, this is the high-level finding there. In the US, there are about 2 million Medicare beneficiaries who are completely or mostly homebound. These are people who essentially never get out of their house over the course of a month, or maybe get out once or twice. And then another 5.5 million people who we call semi-homebound. These are folks who have difficulty getting out of the house or who need additional assistance getting out of the house. The next slide displays the data in a slightly different way, and I think in a way that helps us think about the population overall. So in those left upper two boxes, the homebound that never go out, about 400,000, the folks who rarely go out, those are the folks we're calling completely homebound. Those are the 2 million. And then when we look in the other big squares that have multiple colors, you see in that bottom left, there are folks who go out on some days, and that's about 3.5 million people, 3.6 million people. But you'll notice that even among the folks who go out on some days, about half or still have homebound characteristics. They'll never go out by themselves. They need help to go out of the home, or they have difficulty getting out of the home. And if you go to that large box, bottom right, you'll see even among people who go out every day, probably about 10% of those people also have some degree of difficulty getting out of the home. And next. When we look at the characteristics of the homebound population, I think it's fair to say that they are in general a population that has serious illness and high social needs. So in this slide and in the next slide, you'll see we've talked about the folks who are completely homebound in red, mostly homebound in yellow, and the folks who are not homebound are in green. And you'll see that folks who are completely or mostly homebound are more likely to be among minority populations, Black population, more likely to have lower educational attainment, less likely to be married and living with a partner, and much more likely to have very low income. And next. In addition, the folks who are completely or mostly homebound are far more likely to report self-reported health as fair or poor, which is an indicator that correlates with most poor outcomes in older adults. They're more likely to have symptoms of depression, far more likely to have dementia. That's possible or probable up to 80% among those who are completely homebound, much less likely to be able to walk 6 blocks, and much more likely to be hospitalized within the last 12 months. So people who are completely homebound have experienced hospitalization within the last year of about 50%. And next. These are data, sorry you can't, doesn't project all that well, but we just told you about data from the National Health and Aging Trend Study. We were also curious to see if this was a problem, often an unacknowledged problem, in Medicare Advantage populations. And we had the opportunity to collaborate with Humana. And we were able to, in collaboration with them, put some questions on their annual in-home wellness survey that they do on many, many patients. So we had data on about 500,000 Humana beneficiaries. We were able to assess homebound status and then look at the association of homebound status with negative outcomes. So in the 4 plots that you see here, on the upper left, it's looking at emergency department visits. On the upper right, skilled nursing facility admissions. Lower left, inpatient admissions, and lower right, mortality or death. The top line in each of those figures shows the odds ratios of experiencing that outcome if you're homebound compared to not being homebound. So if you go to the bottom right, the odds of experiencing death approach 3 times that if you are homebound versus not homebound. And you can see it's a more powerful predictor or association than age or dementia status or being frail and having multiple falls. But homebound status is highly associated with all of these negative outcomes, even in a large Medicare Advantage plan, where the overall rate of homeboundness, complete plus semi-homebound, was also about 20%. And next, just to focus in on some of the behavioral issues and experiences, many who are homebound do have significant behavioral health needs. About 40% experience symptoms of depression or depression, 20 to 40% with anxiety, as we know, half with dementia. And there's a lot of caregiver stress associated with caring for someone who's homebound in the rate of 40 to 70%. I'm going to turn it back to Christine.
Thank you. So you heard from Dr. Felker early on that Dr. Leff and I have been involved in supporting those who are homebound and those caring for them through the National Home-Based Primary Care Learning Network for now over 10 years. And we are interested in supporting those who are homebound and those who provide services to them because this population generally gets less access to traditional nuts and bolts care. For many of them, their only way to get care is to go to the emergency department. That is hard and taxing if you're having trouble with getting out of the home to begin with. And this is why we're particularly excited about thinking about the interface between home care and telehealth, and how you all who may be involved in behavioral interventions for those who could benefit from telehealth could potentially be a part of that avenue towards increased access to this homebound population to supporting their behavioral health needs. You also heard that there are a lot of folks who are homebound who have behavioral health needs. And so knowing that people who are homebound often have behavioral health needs, and also knowing that telehealth and telemedicine can be important for any care delivery model, we were curious when we worked with our National Home-Based Primary Care Learning Network, which, as you can see from this slide, constitutes over close to 90 practices who are providing home-based primary care throughout the country. We were curious on what they were doing with respect to telehealth to see how it might have changed the way they provide care, and also to provide insights to you if you're thinking about this population on what you might struggle with or what might be issues for you as well. So when we asked our home-based primary care learning network colleagues about their use of telehealth, this is what we found. First, like a lot of people, they used a lot of telehealth during the pandemic. So during the pandemic, by and large, over 90% of these home-based primary care practices or respondents said that they engaged in telehealth. And then when asked, okay, during the peak of COVID, what proportion of your overall visits were telemedicine visits? You can see that, for some folks, almost a third, it was like the predominance of what they were doing. And of course, we saw this across the board during COVID, is that many people changed the way they conducted practice substantially. There was still a meaningful group of folks for whom this was not their predominant way of provision of care. About almost a quarter said that, that was not, that they were providing a quarter or less through telehealth. But you could see a huge amount of variation. And that's really for home-based primary care when telehealth became more mainstreamed, was during COVID. Then our question was, okay, that was then. How about now? What are you doing with respect to provision of telemedicine visits now? And interestingly enough, not much change from during COVID. So now telehealth, even for folks who are providing care in the home, has been integrated into their practice models. And about the same proportion of practices or participants who answered that they were providing telehealth during COVID are now providing telehealth out past the pandemic. And so then when you ask the question now, what proportion of your visits are telemedicine visits? It's a much lower number, but maybe more right size for what the needs are for this population. And then when you ask, okay, well, what are you using those visits for? You can see that predominantly they're being used for urgent care visits. So someone calls up, they're having trouble. You want to see whether or not you might need to do an in-home visit. You start with a telehealth visit, and then decide whether or not what needs to happen next. But we are seeing routine follow-up visits also being used through telehealth, post-hospital discharge or ED follow-up visits, annual wellness visits, and then other things like wound care, or situations perhaps when weather issues or the provider being sick, or sick patients and caregivers also sort of suggest or support the potential value of a telehealth visit.
Great. So I'm going to talk about some signals on the use of telemedicine, telehealth in home-based primary care. There have only been a few studies done in home-based primary care, and I'm going to restrict the review to that. It's just a few studies. And interestingly, most of the studies, pretty much all of these studies were done pre-COVID. And I think it actually helps us think about what was going on then, and then integrating that with the data that Christine just reviewed, what the opportunities might be for the future. So on the next slide, our good colleagues at UCSF and at Hopkins and in Ireland, Dr. Sheehan, who's a colleague of ours, they did a recent systematic review of home-based primary care. And in their review, they identified 5 overarching themes for home-based primary care. These were themes, thinking about the future of the field. What does the field need to be focusing on? And they actually identified the role of telehealth and trying to understand what that role was and what the proper applications were and how to integrate it and implement it within practice was one of their 5 overarching themes. So from experts in the field of home-based primary care, telemedicine is emerging as an important theme. And next. So this study came before COVID. This was from the VA. The VA is interesting. Veterans Affairs health system is interesting because the VA was using telehealth literally decades ago for certain key kinds of problems. Like they had a telehealth wound service and other kinds of very specialized care. They did a study, and this is from 2019, so pre-COVID, study of telehealth and home-based primary care. And they were looking at the factors and challenges associated with integrating it into their home-based primary care program. So this was a national VA survey. They had a nearly 60% response rate across 232 home-based primary care sites. If you're familiar with the VA home-based primary care, the VA probably has, in some ways, the most robust home-based primary care system because they have mandated interdisciplinary teams. So they have behavioral health specialists, mental health specialists, physicians, nurses, pharmacists. It's really among the robust home-based primary care systems out there. And at that time, nearly 3/4 were using home telehealth. They were most likely to use it when their home-based primary care sites were aligned with their extended care services service line, when there were more disciplines on their care team, and when physicians actually made home visits. Most of their program directors, over 80% of their program directors, viewed home telehealth as a positive modality to manage complex chronic illness, but they noted it wasn't well integrated into the care planning process. And, we have colleagues who are very fond of saying, and we tend to agree with them, that, workflow and care planning processes, workflow is God. And you have to be able to integrate technology into practice in a seamless, frictionless way to make it work. I did like this paper because the figure on the right provides something of a reasonable conceptual framework about how to think of telehealth technology in the context of care coordination with patients and their families and caregivers at the home, but the ability to use telemedicine and telehealth to monitor people, may have an educational function that serves in a feedback loop. So this is just some early data from the VA. This is a study also pre-COVID, and this comes from our colleagues at Mount Sinai in New York City. Their home-based primary care program, for many, is one of the model academic home-based primary care programs. They did a study pre-COVID, and they wanted just to test whether telehealth among stable patients, so these were patients who were cognitively intact and tech capable, or with a caregiver who could operate the tech, and these were assigned to a few of their social workers. And the question they were trying to answer was, did telehealth have the potential to replace some in-person visits? And it's interesting, it's almost a quaint question now to think about in the post-pandemic time, but a lot of these kinds of studies were done early to see whether these things are feasible. Of course, when the pandemic came, people snapped their fingers, and people who were dragging their feet for years all of a sudden were able to do telehealth in about 2 weeks. In any event, in this population, they looked at 56 patients, and about 70% of them had at least one successful telehealth visit. The overall video success rate was about 50% of those that were attempted. And the thing they ran into was a lack of familiarity with the technology and some connectivity issues. Those were major barriers. But they did find that even in New York City, and the population they care for varies in socioeconomic capabilities, that patients and caregivers actually preferred the video visit to longer wait times for visits or for in-person assessments. So, this notion of feasibility of use becomes important. And next. This was another New York-based study, again pre-COVID. This was a qualitative study looking at the care team perspectives and acceptance of telehealth and scaling a home-based primary care program. So they did 16 interviews. They had a few focus groups. They were focused mostly on the medical staff, care coordinators, social workers, and a few key themes emerged. Those were the pros and cons of scaling, the impact of technology on staff autonomy and competence, and the caregiver relation and the provider caregiver relationship. But they did feel that providers could use technology to broaden the reach of their programs, to more fully engage caregivers, and to increase contact between the program and their patients. And they thought a particularly good use of telehealth was for behavioral mental health issues. And then the last study I'll talk about is one that Christine and I were involved with. This was a qualitative study that we did during COVID. We did 13 interviews with folks at 6 New York City home-based primary care practices. And this was getting at the perception of video visits during the first wave of COVID. And what we found that there were some benefits in terms of being able to use telehealth to triage patient needs, collect patient information, to help with scheduling capacity. But again, the barriers in terms of cognitive and sensory abilities, the tech access, relying on caregivers to use the technology, and incomplete exams were some barriers. And I think also, just to reflect, Christine and I had some experience. A few years back, we put together an advisory group of folks who were in our home-based primary care practices and their caregivers. And we had obtained what we thought was the simplest device on the planet Earth to engage with these folks in basically Zoom calls to do discussions and try and understand what they thought about quality of home-based primary care. And even a single push-button iPad-like device proved challenging. So not to underestimate the tech issues. Back to you.
Thank you. So we've been a part of, along with, I think, many of our colleagues at BHI, in trying to think about how to sensitively address the needs, the telehealth needs of older adults, so that the services that can be provided effectively that way are really accessible to everyone, despite sort of their background or their age or their location. And with profound support from the West Health Foundation out of California, have developed some principles and guidelines for older adults. And as we sort of pivot from sort of talking about what we know with respect to homeboundedness and what we know with respect to telehealth and their needs, and how this might be relevant to you as you integrate telehealth for the care of older adults, especially for their behavioral health needs, we thought it might be useful to just walk through some of those telehealth principles and guidelines, specifically as they relate to older adults. So there's sort of 3 major principles for telehealth and aging that we want to discuss with you. And they fall into 3 categories. First of all, being person-centered. Second, equitable and accessible. And third, integrated and coordinated. What do we mean by that? Well, first of all, if we're being person-centered, then there's certainly not going to be a one-size-fits-all. And there are going to be situations where, despite our thinking that this makes complete sense to provide these kind of services through telehealth, that there may not be the same level of openness and receptivity for a host of reasons by those who we are serving. And I think keeping in mind always, first and foremost, what are older adults' care preferences, their goals, their capabilities, that's just always worth keeping in front and center. And these are relevant because for many older adults, there are issues that come up that we don't often have to face to the same degree at other seasons of our life. For example, sensory impairment. Yes, we can have sensory impairment, visual or hearing impairment from an early age, but our likelihood of developing visual impairment and hearing impairment increase with aging And that really can make these kind of telehealth interventions or strategies for care more complex. We'll talk about cognitive impairment and the challenge that that can offer. But then there are other sensitivities that Dr. Leff brought up as well, which is who else is in the room? Is this actually private? Is this something I want to be able to do in this setting? And keeping all those things into account really important. And then the second really has to do with this issue of equity and accessibility and recognizing that, you know, regardless of age, our abilities, our predispositions, what we have access to by virtue of our resources, our health literacy, our technology literacy, these all can play into making telehealth a real value add, like an extension of care in a real positive way, to something that actually can be even harmful. And so being thoughtful about that on the front end as a key principle is important. And then finally, integration and coordination. Well, we all have probably experienced personally in our own life and in our own receipt of healthcare how discoordinated healthcare can be, and telehealth can actually contribute to that discoordination. If we have telehealth, provision of telehealth services that are not actually integrated into a larger conversation around the integrated support of somebody, especially those folks who have complex care needs, we can actually, again, inadvertently cause harm, and we don't want that to happen. Now, as part of our work around telehealth and in partnership with the West Health Foundation, we have been a part of the development of a Center for Excellence for Telehealth and Aging. And if you haven't had a chance to go to this website, it is just fun. There are a lot of great resources on this website. It's CE4TA.org. And you'll see their toolkits for provision of telehealth, how to implement age-inclusive telehealth in a number of different settings, and then case studies that you could potentially even do in your teams to think about sort of what workflows and processes could be beneficial and what workflows and processes could potentially be problematic. So now let's turn to sort of the specific population of folks that we've been talking about, those who are homebound, and talk about sort of what might be some real world application of telehealth for people, especially those living with dementia and their caregivers. And you may recall from what Dr. Leff mentioned earlier in the presentation that over 50% of people who are homebound have some level of cognitive impairment. So this is a real phenomenon and a common phenomenon in this population. And so when we're thinking about supporting people living with dementia, we need to first and foremost understand what stage of their journey with dementia they are in. Sometimes when people are given the label of dementia or the diagnosis of dementia, we make presumptions about what they can and cannot do that are actually not accurate. And so it's worth recognizing that there may be very many people who still have the capacity to navigate technological hurdles in those early stages of disease, and it's important for us not to assume. I'll give you an example. We have a patient family advisory council for our Dementia Care Collaborative, and we have a number of people living with dementia who are a part of our patient family advisory council. Several of them are quite able to navigate Zoom and navigate our Zoom-based conversations without difficulty. Others, and many times over time, folks start developing more challenges with some of the complex sequential behaviors that engaging with telehealth requires. And in those instances, having a care partner or having a navigator be a part of the team to support that person in receipt of telehealth becomes important. I have a colleague in California who has been engaged in telehealth-based palliative care for a number of years, and they've been very effective in using navigators for folks who don't have care partners, who go into the home, set up the equipment so that a telehealth conversation can occur, and make sure that they don't run into trouble during that session. So thinking about how we integrate either the care partner, formal or informal care partner, or a navigator who might be on our team who then goes to the home to help facilitate telehealth is something to consider. During those middle to late stages, it's important to keep in mind that for people living with dementia, verbal comprehension starts becoming more challenged. And even during the course of this presentation, often use pretty complex sentences. We have long sentences, we use and words. And so being much more thoughtful about using simple sentences, using simple questions, those become increasingly important as people enter into the middle or later stages of their illness. One of the real advantages of Zoom over phone-based telehealth, I shouldn't say Zoom, I should say video-based telehealth, is that it can offer visual cues. And so, for example, when you're trying to actually help try to understand, say, diagnostically how someone is doing, you can use your hands, you can mime a behavior, which can be helpful as someone moves into their middle or later stages of their illness. When we're thinking about sort of the diagnostic assessment for persons living with dementia, there are tools that are not predicated on pen and paper or on being in the same room that can be used. There's something that's called, unfortunately, the blind MoCA, but it's a MoCA that MoCA stands for the Montreal Cognitive Assessment Tool. It's now largely replaced MMSEs, as you may know. There's also a telephone-based cognition screen called TICS that can be used. These are helpful for you if you're trying to engage in diagnostic assessment in the setting of a telehealth encounter. Remember that, again, for persons living with dementia, they may easily be able to navigate those technological services, but later, not so much. What about for the care partner? Well, for many care partners, and Dr. Leff alluded to this when he was talking about some of these studies, they're thrilled not to actually have to take their care recipient into a bricks and mortar clinic. The challenge of getting them dressed and in a car and over to another place where there's often a lot of, transferring from one place to the next can be incredibly exhausting. So for some care partners and caregivers, actually virtual care can be a very welcome change relative to going into a bricks and mortars setting. And it can be particularly useful when you're looking at behavioral symptoms to be able to actually see what's going on in that person's natural environment. So you may actually be able to see repetitive behaviors. You may be able to see certain kinds of verbal repetitions that you might not actually see in a traditional office setting. What is important is to have some sensitivity to this dyadic dynamic that may be occurring in that setting. So, for example, it's not uncommon for us when we're engaging in virtual care for people living with dementia for the caregiver or the care partner to somehow think that they don't need to be on Zoom, and then you can't really see the dynamic, or for the care recipient also to not be a part of the Zoom. So it makes it more difficult to understand and navigate the dynamic, or maybe that the setup doesn't lend itself to that. So being aware of that dyadic dynamic, being aware of some of the privacy issues that we brought up earlier, and also being aware of other folks that are maybe in the backdrop that you're not seeing. There may be other family members in the home that are sort of lurking around that you can't see in a virtual environment that it's worth asking about and being sensitive to. It's also very important to keep in mind that many caregivers are stressed. About 1 in 3 caregivers of people living with dementia report depressive symptoms. 20% have suicidal ideations. They desperately need behavioral health themselves. And so having access to behavioral health providers through a virtual care context can be extremely valuable. And for many care partners who say that it's virtually impossible for them to go get any kind of care themselves, to have access to behavioral health in the home could be a real game changer. So to sum up, we hope that we've been able to impress upon you the importance and relevance of the homebound older adult population in the need for telehealth, and specifically for behavioral telehealth, and also to hopefully give you a few little tips on adaptations that could be helpful and necessary to optimize the quality of services that you provide, their uptake, and some of that reduction of friction that can be really important to make these encounters a net positive and really important for improving quality of care and quality of life for this population. So with that, we will conclude and turn it over to our hosts.
If we want to look at, do you want me to read out the questions to you, Christine and Bruce?
That would be terrific. Thank you so much.
Sure. So from Florence, there is a large portion of adults, Pew Institute 40%, who in addition to having access issues such as broadband and cost, have no or little knowledge on how to manage devices and telehealth platforms safely. For example, awareness of scams and such. Training these adults, especially with some cognitive impairment, is the first necessary step towards equitable access. How can we effectively address this critical challenge?
Oh, what a great question. So first of all, giving voice to it like you just did is a start. The other thing I would say is that having some mechanism to consistently assess for it is pretty important, and to just sort of weave that into your work. So some of you may do this already, but in our mind and memory care program, which is essentially focused on people who may be at risk for the development of cognitive impairment or who are developing cognitive impairment, we have a series of questions that we ask, and one of them specifically addresses scams. Scams are just so prevalent and increasingly creative, and I think they are things that we really have to do two things of. One is just do that assessment, and then have at the ready some tools and resources, of which now they're increasing numbers. The Alzheimer's Association has quite a few on their website for people who are living with or developing dementia. Those are things that we really need to have at the ready for folks, because many times this comes on unawares, and then a daughter or a son suddenly is going, oh dear, what just happened? There's 5 new credit cards that, my family member has that they didn't have before and that are not helping them.
Okay, second question. Perhaps you can address the financial support for a navigator or support and equipment to improve experience of telehealth. Would this be state, federal, insurer funding? Many particularly low-income, homeless, and rural populations simply don't have resources and accessibility.
Great question. So a lot of these programs are most feasible in a setting that's not purely fee-for-service. So in a pure fee-for-service setting, it's very difficult to accommodate this unless there is state funding, county funding, philanthropic funding. In value-based care delivery models, where you're able to demonstrate the ability to actually reduce overall cost of care, then many times one is able to advocate for and procure additional support and services, resources for these kind of services. But it does require being in a setting where that's feasible. So for example, when I was living and working in California, we worked with a number of value-based care organizations who saw the value of the provision of these services and basically saw that it was cheaper to have a navigator go into somebody's home and set them up than to actually have an ambulance bring that patient into the clinic. And so for those reasons, they were willing to get creative around these kind of services. But you are right, it's not straightforward. It requires a good bit of creativity. I would work with your local municipalities, because many of them do have increasing interest in this space. I know for the city of Boston, we're now doing a lot of work in integrating navigators into provision of services around telehealth, but it is hit or miss. And it does require, I think, a lot of creative thinking, not baked into our reimbursement model yet.
Another question. What if there is no home care partner to help assist? How can we help get that for our patients?
So there's many different kinds of home care partners. I'm assuming that the question relates to like a home-based primary care practice or that kind of partner. A good place to start is the Administration for Community Living, or what used to be called the Triple A's. Those programs often have specific services in the home for older adults, especially functionally impaired older adults. And I would start there. Now, how the Administration for Community Living actually translates out in any particular region is highly variable. That being said, they will often have they would be a good place to start. In addition to that, if the person is Medicaid eligible, then many times they may be candidates, especially if they're homebound, for home and community-based services, because what Medicaid is doing across the country is they're trying to give more people the opportunity to age in place and not go into nursing homes. And the only way they're able to do that are through the provision of a much more robust set of home and community-based services than used to exist even 10 years ago. And so that would be an option, but frankly, it's only an option for those folks who actually are Medicaid eligible, which is a relatively small population relative to that very large group of people who still have limited resources, but aren't Medicaid eligible.
Okay, great. Oh, thanks, Michelle. Posted some information in the chat with a link for seniors in service, I think, but it says it's probably just for her Tampa Bay, Florida area. But thank you for posting that. Great. Any other questions as we're wrapping up the day? Let's see. The nonprofit started in Eugene, Oregon, places tech with disenfranchised community. Oops.
Love it. Next Step Recycling.
Yeah.
Thank you for doing that work. This is very encouraging to hear.
Yeah. Yeah. This is great. And I mean, maybe you talked about this, but I imagine that partnering with home health agencies could be helpful as well.
Absolutely. So home health agencies are usually providing services in a fairly constrained and circumscribed way. The way that Medicare pays for skilled home health care in this country is on what they call episodes of care, which are usually in 60-day increments. And it's no longer sort of the longitudinal type of care that earlier in my professional life was more the norm. And so if they are in that person's home, or there's a good reason for that person to receive skilled home health services, they can be great partners. And if you have home health agencies that have a mission-focused spirit on the care of this population, many of them will have also access to other community-based organizations that could then be partners as well.
And this isn't exactly homebound, but do you also work with skilled nursing facilities or assisted living facilities to do telehealth visits that maybe pull in a remote family member or something?
Right. So assisted living facilities are, in some respects, the sweet spot for provision of telehealth, because there are people around that often can be availed to support the setup, and they also are there if something goes awry. So assisted living facilities are really great places to potentially have sort of, if you want to get your toe in the water for provision of services for this population, I think assisted living facilities are a good place to start. That being said, the other thing I'll say is back in the day, assisted living facilities used to be only for those who are able to personally pay for them. Now, in many states across the country, their assisted living facilities are being integrated in healthcare delivery in the same way that nursing facilities are. And so there is, I think, more socioeconomic heterogeneity than there used to be with this population.
Comment from Deanna. Some health insurance companies have social workers that evaluate their insured. Perhaps insurance companies have resources to provide. Sorry, I keep losing the end bottom of the line. To provide assistance, maybe it says.
Right, to provide technology. Yes,
Yeah.
so I would encourage those of you who are really interested in this space to think about working with insurance companies, because the insurance companies often are the most likely to gain the benefit of the services that are provided, and often have deeper pockets than anyone else. So we'd certainly encourage that tactic as well.
Great point. Yeah, well, thank you. And to Dr. Leff, who who had to leave a little bit early for this presentation, and for all the work that you're doing in this space. It just, gosh, it feels like a yin yang of, this is the population that would really benefit from telehealth, and yet it's sort of a challenge. There's lots of extra moving pieces to coordinate to offer these services. So we really appreciate the work and that you're doing and the guidance that you're providing. So thank you very much. And we hope to see you next month. And I wish you all a very lovely weekend.